Hello, everyone. We are coming to you from San Diego in ACR 2023. You just joined the Psoriatic Arthritis panel discussion. In this podcast and video, we're going to discuss amongst the psoriatic arthritis faculty some of the highlights from ACR 2023 on the topic of psoriatic arthritis. We'll be doing topic podcasts in multiple areas, including RA, lupus, SPA, JACin, but this one is all about PSA and all things psoriatic. I'm going to ask my faculty to introduce themselves. I'm Jack Cush in Dallas, Texas. Orly
Hi, I'm Aurélie Nage, Glasgow. Nice to be here.
and
Robert
Robert,
Chow from Virginia.
Dr. Robert Chow from Virginia. So we've got the globe covered. Uh, First, I want to get a quick report from both of you about your experience. Orly, you were at the meeting. You flew all the way from Scotland to San Diego. Thankfully for you, the weather was good. What do you think of the meeting?
Yeah, I think it was really good. It was the big highlight for me was the return of the live posters where and it was massive. There was a lot of science, a lot of posters every day. I really enjoyed that. That for me was a massive highlight. And I think, San Diego is just a nice place to be. It's sunny, it's nice, the conference center is good, you have this view on the bay, you can have a break in the sun. So yeah, I mean, I've loved it.
Yeah, it was good. And at break time, you could go outside, walk around, and get some sun. As Robert Chow knows all too well, as he trained in San Diego, but he didn't make it. You did this virtually, Robert. How did that go?
I think the virtual format is getting better and better every year. Less laggy this year. I think maybe just because less traffic, because everyone's probably in San Diego. They made it very convenient for us folks attending virtually. You could filter by live stream, made it very easy. So the virtual format is great. I think we have a tough job. I know ACR's in DC next year, my home turf. We probably can't compete with the weather, so we'll see. It wasn't terrible here though, but it's not as nice as San
Yeah,
Diego.
that's yeah. Luckily, it was okay for you. But I want to reiterate what Orly's just said, that the big obvious thing was, aside from being back at a live meeting, was the poster floor. Poster hall was just seas of people, and you couldn't possibly walk on that poster floor and meet people who you haven't seen in a while, see new things, see the giants of rheumatology alongside the fellows of rheumatology. I mean, it's a great mixing experiment. It's a great way to learn and discuss, and it's almost like they should have it for 4 hours rather than the 2 hours that they run it, because it opens at 9, and by 11 you've got to run to the plenary session. So, but I agree, it was a highlight. All right, let's get into it with what we thought were some of the big PSA content delivered at ACR 23. Orly, why don't you begin?
Yeah, so I want to talk about the ISER study. So it was abstracts 0495. So I think it was really interesting. We always have these patients with PSA or AxSpA that, have bowel symptoms, and it's sometimes quite hard to know whether, it's IBD or not. They also take NSAIDs. And so this study, what they did is that they took a cohort of over 500 patients, and a third of them, 35%, had PSA, and the rest had AxSpA, radiographic or non-radiographic. And so what they did is that they looked into the fecal calprotectin in all of these patients. The mean time of diagnosis was about 12 years. So these people had well-established disease. And the cutoff they choose for the calprotectin was 80 microgram per gram, which is a bit lower than the 100 that is normally used. And if they had a higher calprotectin than that, they would then go for an endoscopy. And so 50% roughly of the entire cohort had abnormal calprotectin, so over the cutoff. And so they all underwent a a colonoscopy. And what was interesting as well is that 80% of these either had radiographic axSpA or PSA, and the non-radiographic guys were only 20% with abnormalities. So when they did the colonoscopy, 40% had features that could be concordant with IBD. And I think one thing that is a bit of a shame is that there were no information about, whether they were taking NSAIDs, what the dose was, and even what treatment they were in general, because I think that obviously might have an impact. But amongst these people, this 40% that had abnormal colonoscopy, 40% only had symptoms. And 10% had an history of IBD. But so in the end, they diagnosed 4.5% roughly of the cohort, so like 20 patients with definite IBD. The rest they don't really say, but I would assume that it's probably, treatment related and NSAID related. But what it means is that technically across this cohort of over 500 people, 23% had undiagnosed IBD. Which, as you think of it, is quite a lot.
Right.
So I think this is something to keep in mind, definitely.
Yeah, there's been some reports in some of our last meetings that this is something that's been thrown around, but I don't think something quite this large a cohort or quite so systematically studied with everyone getting fecal calprotectin levels and then that being this decision point for colonoscopy and further evaluation. So Robert, what was your take on this data?
Yeah, I think, I feel like sometimes every meeting we go to is we become more and more GI docs. It's always gut microbiome, probiotics, right. And now we have to do calprotectin. But jokes aside, I think, I definitely, without a doubt, I can't. Just so many patients I see who, when you ask them necessary questions, oh yeah, I have these symptoms. Have you seen a GI doctor yet? And I think most time it's really, the way I explain it to patients is they come see whoever they have or wherever they have issues, right? If they mainly have joint issues and the diarrhea is not terrible, they may not go to the GI, or they kind of put that in the back burner. So I think obviously we know as rheumatologists, we kind of act almost as a surrogate primary care for the most or the majority of patients, and getting that early recognition and hopefully ushering them to the right specialist in a timely manner is important.
So the problem I see going forward is that what I heard from a lot of the psoriatic arthritis and SPA experts is that fecal calprotectin has sort of fallen into some disfavor, meaning it's overly sensitive, right? It picks up way too much. It's not all that easy to measure. So I don't know that we have a good screening tool other than asking a lot about GI symptoms or having a low threshold to do capsule colonoscopy, the capsule camera colonoscopy. What would do either of you have a recommendation, since basically the yield is 5% of all PSA and SPA patients will have this? It's easier if they got a lot of GI symptoms, but one of the messages of this was that a lot of these people don't have any symptoms. Majority. So what's your screening tool going to be, if not calprotectin? Orly?
Yeah, I think it's a tricky one, and it's even trickier because then all of those that had abnormal colonoscopies and weren't diagnosis, what do we do with these people as well? Because and then shall them just stop the NSAIDs and just recontrol, and shall we do that? So it's even trickier than that, because it's not only the 5%, it's the other 35%. But I think there is no good tool anyways. I would still go with the calprotectin. I will maybe up the cutoff a little bit, because I think 80 is even lower than what we usually go for, so you will pick up even more people. Or maybe combine the calprotectin with the clinical score, but then you miss all of those who don't have symptoms. So I don't think there's a good answer here. I don't know what you think, Robert, but
yeah, I wonder if this is, I don't know, this is a phrase that we could use, but like like for our preclinical RA, I wonder if this is like a pre-IBD that I simply don't know enough about, and I think it is a tricky question to answer. Personally, again, I think I try to go off of at least some symptoms before I make that recommendation. I don't know if I have enough confidence, I would say, in this
Right.
surrogate marker.
What we don't know and probably wouldn't be all that helpful is what other markers were available other than the fecal calprotectin. But since they have a spondyloarthropathy of some sort, finding an elevated SED rate or CRP may not be all that valuable. Finding some anemia may not be all that valuable. I think what maybe the take home is going to be is this kind of research, as Dr. Chow has said, which seems to be repeated these days, and when we go to these meetings, this idea of occult GI disease looming in people with either SPA or PSA should heighten our awareness and heighten our looking for other. I just need a reason to go the next step and do the GI referral or do the camera study. And I think that or to do look for blood in the stool. I think that makes sense. But and I think that the people like the both of you are into PSA. So you'll be kind of thinking this way. The average rheumatologist who just has PSA patients and may not consider themselves a SPA PSA expert may not be thinking of this, but hopefully our reporting about this repeatedly will get them to have a heightened sensitivity to this issue. Interesting study, nonetheless. There was a lot of talk about this at the meeting. I want to tell you. Dr. Chow, what did you like?
Yeah, so I always like to focus on imaging and enthesitis, and of course, by imaging, I mean ultrasound in this case. And this was abstract 2243, based off of the ultimate study. So just to recap that was a year-long 52-week study that demonstrated responsiveness of ultrasound detected synovitis and enthesitis in psoriatic arthritis patients, and then confirmed secukinumab's efficacy. So this was then going to look at, is there any relationship between ultrasound detected enthesitis versus clinical enthesitis? So, pretty much clinical enthesitis is the traditional, I poke you there, does it hurt? If there's a potentially a tendon, maybe enthesitis, right? And then ultrasound, of course, we understand is power Doppler and looking for other markers, through the muscular skeletal ultrasound. They enrolled 166 patients. And in terms of the clinical enthesitis, the scoring system was by the Spark Index. Ultrasound was by power Doppler, like we mentioned, across 6 sites bilaterally. Again, emphasized that over 52 weeks, both clinical and ultrasound enthesitis had sustained resolution, and over 50% in both arms, so efficacious in those regards. But the most interesting finding was there was no correlation between clinical and ultrasound enthesitis. So I think, again, emphasizing, at least I think, and most clinicians in rheumatology nowadays may be shifting more towards an ultrasound and image guided objective kind of enthesitis evaluation versus the traditional poking mechanism, if you will. And the second thing I find that patients, I think, find very fruitful and rewarding is usually, if you're not doing it at bedside, or if you send them to a radiologist, they can see the findings real time. It's there, and it's hard to miss, even as a layman, if the power Doppler lights up. If you see those little flickers and flames, that's as telling as anything. It's not like some rocket science that a radiologist has to read. And most of the time, I find a radiologist is also very informative with discussing with the patients too, as they scan real time. So I think it just puts a little bit more emphasis on the ultrasound kind of guided evaluation of enthesitis.
You're talking about this from a standpoint of detection, and an ultrasound's got clear advantages that are different than what the exam. And I don't think most rheumatologists do a good enthesitis exam anyway on their patients with SPA and PSA. They probably should, because it's as important as a swollen joint. But did they also look at this from the standpoint of response to secukinumab? Like, did the enthesitis by ultrasound respond differently than enthesitis by clinical exam?
Yeah, no, they responded similarly, especially in the secukinumab versus placebo arms. If anything, I don't think there was a statistical significance. I believe the Spark No, they were roughly about the same. I think a few percentage points. You look at the spark and actually the ultrasound. The thing with this though is because I'm not ultrasound expert per se, but they also had two definitions. One was power Doppler only, and another was power Doppler plus some other factors. But when it was power Doppler only, it matched up pretty well with the
Right.
clinical
Yeah,
evaluation.
that's something I wanted to ask you about what the definition was for the anxieties as well on on ultrasound, because I do a lot of these in my clinics, and it's a clear continuum. You're gonna have, it's not a yes or no. It's a very difficult questions to answer. So I would, and sometimes you have really a lot of damage and no Doppler, but people are in a lot of pain still. So it's a tricky one. So they used only Doppler or Doppler person as a feature.
Yeah, they
Yeah.
used Doppler for one definition, and
Mm.
another was Doppler plus what they called a combined B mode
Okay.
morphological abnormalities. And I think for us, in rheumatology, I'm assuming that means things like enthesophytes, maybe some tendon swelling and maybe, other things we see besides just the power Doppler lighting up.
So Orly, as one who does a lot of ultrasound in such patients, are there many examples where you change your treatment or initiate treatment just based on your ultrasound findings of enthesitis in these folks?
Yeah, so it's a difficult one because what happens sometimes is because the way they present is similar, and you're gonna scan them and suddenly you see this Achilles tendon, and it's very hypertrophic, and there's erosions on the enthesis, and there's like deposits, and there's enthesophytes, and you and there's Doppler everywhere, and you think, oh my God, the disease is really active. But the problem we have is that we know that none of our drugs are really efficient on enthesitis anyways. And so if everything else is doing well, it's a really difficult decision to take. I personally, although we don't really have evidence, tend to intensify or change something, taper up when I see it. But the other thing, it makes me think of this other abstract that I can't remember the number that was presented, where they looked at different phenotypes according to the ultrasound findings, and it wasn't clear at all, and it wasn't clear if it was associated to better response to different. So I think it's a difficult one, but I would do something, not necessarily switch, but do something.
Right, right. Again, I have an ultrasound machine, and while I'm not expert at it, enthesitis I think is at my skill set, and should be used more readily, and especially people who have pain. And when you really want to know, is it just damage and as opposed to activity with inflammation, and also is it fibromyalgia is another, because a lot of FM pain shows up as enthesiopathic like pain, and I think that can be the big confusing clinical question. So, all right, mine was a late breaker from was a late breaking poster that's been up for the last few days. It's a new TYK2 inhibitor from Takeda, and it's called TAK 279. It's abstract number L12. And it got a fair amount of discussion and play. It's a study of this selective TYK2 in patients with psoriatic arthritis. It's a double-blind, randomized, placebo-controlled trial of 290 patients with PSA who either received placebo or one of 3 doses of TAK 279, 5, 15, and 30 milligrams once a day. And they looked at ACR 20, 50, 70, and PASI responses at 12 weeks, 12 weeks being the primary endpoint. Obviously, safety and skin responses are important here. And again, the primary endpoint was an ACR 20, and that was achieved in 53, 54% at the 2 highest doses, 15 and 30 milligrams once a day. The lower dose, maybe the inconsequential dose, was only 35% ACR 20, and the placebo response rate was 29%. The ACR 50 was pretty close to 30%, and that was better at the 2 top doses. ACR 70 was about 13 to 15% and better than a 5% placebo response rate. PASI showed a stepwise fashion with dose. But the PASI 75 was only 46%. So, but the problem with doing PASI scores in PSA trials is that the PSA trials are done by rheumatologists who are variably so-so at doing skin exams and not really well trained. But rather than blame the rheumatologist, I'll blame the patient, because most of our patients really don't have much in the way of skin disease, right? It's not uncommon for them to have, body surface area BSA of less than 3% going in. So you may not have much to deal with. So it's not really I would not say one of these trials in an ACR meeting is a good judge of what this TYK2 inhibitor will do skin wise. I think, for that, you're going to have to refer to the current TYK2 inhibitor that's in the marketplace, deucravacitinib, where it's certainly better than this, but it's not as good as what you're seeing with the 23 inhibitors and the 17s, and now the dual 17 inhibitor that's approved. Those numbers look really fabulous for plaque psoriasis. They're not yet approved for psoriatic disease. So, but this is still I think a new entry. It seems like it came in pretty clean. Maybe not the best data ever, but certainly on par with what I might have expected. But you guys are the experts. What do you think of these numbers and these data and this drug, Orly?
I just wonder how I would position it, because it as we have deucravacitinib that is probably going to arrive, and I don't see this being better than that. And so then my question is, where if we can get another 3 or 5 of these compounds, but if they all work the same way, or then do you really want to use them if you already have one? I think that's always going to be the yeah. And also we have this there was this other compound that was looking very good, the I can't remember the name of was it TL08, I think.
TLL018. That was studied in RA.
Yeah.
But it's going to show up, and that's a China study.
Yeah.
The combined TYK2 JAK1 inhibitor that had phenomenal RA results, but the study was only done in China.
I
Only
know.
100 patients, was better than tofacitinib, and they plan to do a much larger trial, again only in China, for next year, and they also plan to do it in psoriatic disease. That everyone's got their eyebrows up on that one, but you're right. When these new drugs come in, the question is, it's above applesauce. It's above a non-steroidal, but where is it going to fit with between amongst the methotrexate, apremilast, other oral compounds you can do, and then you can go to TNF inhibitors, JAKs, 17s, 23s, 12, 20. Obviously they are lower entry items, and when it's in just a second me too TYK2 inhibitor, it's going to have to do something to compete with the existing TYK2. Robert, what do you think?
Yeah, I think data is always good, and the new drugs on the market is always good, but it comes down to, like everyone's mentioned, how does it separate itself? Right now I think with all of these drugs, you just look at the PASI scores versus the ACR 20 and 50, and they don't really kind of separate themselves, right? And you just mentioned the IL-23s are so phenomenal, and even the 17s are so phenomenal for psoriasis. For psoriatic arthritis, it's, like you said, another kid on the block. And like most rheumatologists, we're probably hindered by what the payer allows us to prescribe, and number two, really some out of rheumatology preferences. Do you like needles? Do you want only a pill? Do you want, are there certain things that predispose you to not receiving this drug? And then I think for this one, for the TYK2s, if they continue to kind of separate themselves from the JAK inhibitors, and of course the oral surveillance study and the black box warning and things like that could kind of form its own niche. And I think that'll be a welcome aspect to this field.
All right, let's move on to our next one. Orly, what do you have?
Yeah, I have abstract 1641. It's the window of opportunity in PSA. I thought it was a nice abstract. So they looked at a big cohort around over 800 PSA patients. And so what they were interested in is knowing if the outcome at 3 years is similar or better or worse if people are diagnosed and treated within the first 12 weeks of symptoms, between 12 and 52 weeks of symptoms or over 52 weeks of symptoms. And so the first thing they looked at is what is associated with being diagnosed later. So being a woman, having a lower CRP, having less swollen joints, and having more enthesitis, which basically means they're taken for, having fibromyalgia. And maybe some of them do, I don't know, but technically they're diagnosed later, and people that were diagnosed later in this study at 3 years were less likely to achieve low disease activity, to have they had a higher DAPSA, they had also a higher ASDI. They basically they were doing worse. The only thing that wasn't significantly different was the radiographic progression, but it was numerically also worse. And so I think we need to rethink a little bit the way maybe we're biased in the way we treat patients. I don't know, but I think this is something that we definitely need to keep in mind because it has consequences in the way they will do in the future.
Did you, again, a window of opportunity, did they actually show you, though, that an earlier diagnosis was a different profile and a different outcome?
So less than 12 weeks and 12 to 52 weeks, there was no difference. So basically what they were saying is that if you manage to diagnose within the first year, you're fine. There's not going to make any difference. But if you do delay over than a year, then this is where it starts to have consequences in the ability to reach minimal disease activity at 3 years.
So they're sort of arguing against a window of opportunity in many ways, or they're making that window really wide.
Yeah, it depends of the size of the window, I guess.
Right. Well, that's interesting. This is a highly contestable issue. Robert, what do you think?
I think this is a perfect kind of circle back to the enthesitis ultrasound. You just mentioned the patient population that's not diagnosed are women who have not many symptoms, but maybe some enthesitis. And I think, for that kind of niche group of patients, that's exactly the population where I think ultrasound and some more, again, objective data makes it easier to sell to the patient, quote unquote, sell to the patient, and even to us, the need for DMARDs and biologics, right? Because if you see on the screen, as a physician and the patient sees it, okay, there's inflammation and we need to act on it and act on it, aggressively and early, because we know we have a lot of, sort of drugs in our arsenal here for this.
I want to just flip the story from a little bit away from the window opportunity and more towards what you sort of really spelled out, Orly, which is women being diagnosed late and being atypical. So yeah, some of that could be fibromyalgia, but I think that this cohort is a difficult cohort. Women are presenting late, getting diagnosed later, have atypical symptoms, including enthesitis, may not have sky-high CRPs, and all this contributes to why one of the many reasons why women don't do so well, especially in PSA. And this is, I think, the really big challenge for all clinicians right now, that they need to tune in to what's going on with women. And it's not just that they have fibromyalgia and they feel things more differently or something like that. I think it's there's I mean, I learned this a long time ago in the spa world that women present older and they have a lot more pain and the functional consequences are greater, and it's not fibromyalgia. And so I think this is a tremendous challenge for all of us. So, Robert, what do you have as your next one?
Yeah, my next abstract is not necessarily psoriatic arthritis dedicated, but intersecting with the AxSpa world, but focusing on the drug we definitely use across both spectrums, which are NSAIDs. I feel like anytime I even prescribe an NSAID, I get like death stares through Epic, from the nephrologist on that patient's team. And this was looking at it's abstract 1394, really stating, and the title is very, very frank: comorbidities, not long-term use of NSAIDs, are associated with CKD in AXPA patients. So it's a large Korean study. They looked at over 12,000 AS patients. 120 were identified with CKD, and they looked at the risk factors. They even they also assessed the NSAID. They called it the NSAID intake score, which is pretty much a cumulative dose or amount of NSAIDs you've taken around 3 months, 6 months, in 1 year. And ultimately, they found that the incidence rate of CKD was about 4.64 per 10,000 patient years. And the factors that were significantly associated with CKD were age, the Charlson Comorbidity Index, which I had to look up, which has your typical kind of players: diabetes, obesity, and such, and heart disease, and CHF, and a slew of other factors. Hypertension, diabetes, and then they found that the odds ratio when adjusted for comorbidities and medications did not have a correlation with NSAIDs, whether it was 3 months, 6 months, or 1 year, based on their NSAID intake score. So, I was trained where, I know a lot of kind of young trainees, and your good friend Artie Kavanaugh mentions us young kids, sometimes we forget about all the NSAIDs that are available. And we kind of just jump straight to biologics. But I'm not shy to try a few NSAIDs. And, although there's that stigma, and I know obviously the CKD and AKI risk does exist, but, I think this is a study that tells us that not to be at least shy in the beginning stages to give NSAIDs a proper try in these kind of patients.
So the association with NSAID, between NSAIDs and comorbidities, is that casual or causal in your eye, or by how they presented it? My worry is that they're getting NSAIDs because someone's afraid to give them more aggressive therapy, and maybe they're afraid because they have comorbidities. And the people who don't get treated aggressively are older, and people who have comorbidities. So, what do you think is the association here?
Yeah, I think obviously they didn't obviously comment on that, but I think, of course, just pragmatically and logistically, that does make sense. And I think in everyone who, the first thing I look at when I even prescribe NSAIDs, number one is the allergy list, and number two are what kind of comorbidities are you presenting with? And of course, all of us are a little bit trigger shy when we see that long list. Of course, if someone comes in with all the things I mentioned, hypertension, diabetes, and any bump in a GFR, I may get trigger shy. But I think just overall, if you compare apples to apples and everyone's quote unquote healthy at initial kind of presentation, this tells us not to be as afraid as one would make us feel.
Yeah, and I mean, they do point out a higher rate of cardiovascular events, but it's not gigantically higher. It's 17 versus 14 per 1,000 patient years with non-steroidals, and while that may be significant, it's not gigantic. And the fact that NSAIDs are not associated with an increased risk of CKD, I'll ask the two of you, just as Robert just intimated. I'm the old guy, you're the young guys, and when I talk to the young fellows and whatnot about the use of non-steroidals, they don't use very much. They don't use much in the way of pain medicines. And Artie and I, we got started in clinical trials doing non-steroidal trials. So, and yes, it was back in the days when there wasn't a lot more than non-steroidals. So everybody was on non-steroidals, and the non-steroidals were $1 billion business. I mean, the whole FDA hearing on the COX-2 inhibitors happened because when you turned on the television on Saturday and Sunday, there were more ads for COX-2 inhibitors than there were for the amount of money spent on one COX-2 inhibitor was more than all the ads for tires, beer, and something else big, all put together on the Sunday and Saturday sports shows. And of course, that all translated to how much the government was spending and whatnot. But the idea was tremendously big market. Now they're not really that big at all. So I'm asking you both, do you use nonsteroidals very much? And if you don't, what are you using instead, orally?
Yeah, well, I'm guilty, you know. I use them a lot. I use them a lot, and you know, I think what I've been observing, you know, over the course of my short career so far is, you know, a trend towards, you know, GPs also kind of being more reluctant to prescribe them, yet all the patients are taking opioids. You know, and I've seen this trend, you know, and it's absolutely like crossing that way. Less NSAID, so more pain than more opioids. And, you know, one of the things I do all the time in my clinics is saying, hey, I think, you know, we should probably go back to that non-steroidal you were taking before, and maybe, you know, drop the other one down.
Yeah.
Yeah.
Robert, what's your practice days?
Yeah, I mean, of course, you know, I try to use NSAIDs when appropriate, and I think going back to what you just mentioned about how those drugs were advertised, it's hard for us because it's not advertised, right? So there, if I say, hey, why don't you try Celebrex, they're gonna say, what? I saw Humira on TV. I saw, you know, whatever
Right.
Cravacitinib on TV. Why it says told me to talk to my rheumatologist about it. Why would I use a drug that's many years old, and when there's this newer one, and newer and shinier is better, you know? So
Yeah.
it makes sometimes we're our hands are kind of tied behind our backs a little bit about that.
Yeah, Dr. Google and the television do drive a lot of behaviors in the clinic. My one is the Invigorate 1 and 2 trial. Invigorate is the studies done to prove the efficacy and safety of intravenous secukinumab. The one trial was in AxSpA patients, and the number 2 trial was done in PSA patients. The PSA was almost 400 patients. The primary endpoint was an ACR 50. Patients were given, you know, they basically compared I guess what is this? This is a placebo controlled, and then they cross over. Well, actually, it's the IV, isn't it? How did this go? It's placebo IV secukinumab versus the real IV secukinumab, and then they do cross over at some time point. And again, the response rate with the IV was 32% with an ACR 50, and it just got better over time. This was the basis upon which the drug was approved. The interesting thing, of course, about this is the dosing. So the dosing that was used in these trials was, if you had not received it, you got a loading dose of 6 milligrams per kilogram, and after that, you got 3 milligrams per kilogram, I guess every month going forward. When it came for this drug, time for this drug to be considered by the FDA, other trials were in play, and the FDA gave the company the choice of either doing more trials at 3 milligrams as a repeat dose because they were worried about some peak Cmax levels being higher than what they expected, and they wanted more studies, or they gave them the lower dose. So 6 milligrams is the loading dose, but now the dose that's in the product label is 1.75 milligrams per kilogram. And so that's what's currently approved for both SPA and PSA. And I think that we're happy that the IV choice is there. It's going to be good for Medicare patients. It's going to be good for patients whom compliance is an issue. It's got other indications, but it doesn't have the flexibility of dosing that you would want. So again, it's going to be dosed on a milligram per kilogram basis. But is this a big matter? Oh, and by the way, if you want to hear a better presentation on the Invigorate 1 and 2, Atul Deodar, who gave the presentation at the meeting, did a nice video for Room Now. It's on our channel, and you can hear that as well, or see that. But for Robert and Orly, is this an important addition to you, or it's just another thing to have now an IV option? Robert?
I think for me, in terms of AxSpA treatment or psoriatic arthritis treatment, it probably will be mostly payer dependent, you know, in terms of Medicare coverage and such. But I'm actually more excited for the IV formulation of this in PMR and GCA and things of that sort, actually, and helping that population of patients get treatment And I do see a very good niche kind of territory for that with those patients. But for psoriatic arthritis, and again, the patients tend to be a bit younger and they tend to like the at-home subcutaneous, which we can sometimes, I find some patients respond better to the 300 milligrams every month or 150 every 2 weeks versus the kind of standard advertised 150 every month. And I think the typical psoriatic arthritis population, they tend to like the at-home subcutaneous injections.
So just for the audience, Dr. Chow is referring to the Titan study from 2 years ago, which was a GCA study using secukinumab, showing really impressive results. That was an early phase 2. There's a much larger trial in progress and other studies, I think, being planned for PMR as well. That's not currently approved, obviously, but it is a novel new addition to how IL-17 inhibition might be used in the future. Orally, an IV option for you. Is this available yet in Glasgow?
No, no, no. I don't think it's available, and I don't think we're going to use it that much. To be honest, I think for me, I mean, most of the patients are quite happy to use the subcut, and so there is not much population for that. There's only one thing though that I'm thinking, but we don't have the data. Would be whether that would be better because it's a weight based dosing for people that are overweight or obese, and I'm wondering if that could make a difference for them, because we know that for example with infliximab there's been so yeah, I just wonder if that could be helpful, but we don't have the data.
Yes, I was listening today to some PSA experts talking about this, and that was a big point. The availability for Medicare patients who can now get this, and now it can be paid for, and it helps them. And then clearly there are some patients in whom administration, compliance, and whatnot, and basically patient management issues, it seems to work out well. So it's probably going to have its niches where it will grow, especially in places that have infusion centers and they like doing a lot of infusions. So why don't we just do a few more of your favorites and then we'll wrap this. Orly, do you have another one?
Yeah, I think so. Yeah, there was this probiotic one, this 0778. It was a small randomized controlled trial where there were 30 patients, I think, in each group, and they looked at the probiotics. So it was a combination of a lactobacillus and a bifidobacterium, and they combined them and then they gave them to patients. It was placebo controlled, but it doesn't work. It genuinely doesn't work. There was no different on even the gut parameters actually were not really modified either. And so I wonder if it's just the strains that they selected that maybe were not the best, because I think this is basically what you find in yogurts as well. So I wonder if it's the intervention or the choice of the strains, that is, but in this current state, clearly we can say it doesn't work.
So unfortunately, well, before I taint this discussion with my own biases, I'd like to hear from Dr. Chow.
Yeah, I actually wrote about this. I think a few things with probiotics. Number one, it has pro, right? So it has to be good, and it's very easily accessible to patients. And I think whatever it is, food industry has made a very good PR campaign with probiotics. It has to be in everything. I even wrote my cat gets probiotics. His veterinarian, recommended it. But when you look at the data, this is a small study, but it doesn't work. So it kind of begs the question: what are we really doing? With this? Maybe obviously outside of psoriatic arthritis, there is maybe some other gut microbiome of taking probiotics, but at least in psoriatic arthritis, I don't think there's enough data just yet.
Yeah, I mean, this does not endorse it, and I would recommend everyone practice in an evidence-based fashion, and which means that you should turn off your sound at this point for what I'm about to say. And I'm sort of reasonable believer in natural medicine and, vitamin therapy and whatnot. And I look for evidence, and I think there's certain things I might recommend. Obviously, I'm there to protect the patient, and I'm also there to uh, pre, uh, make sure that they're not being harmed, either medically or financially. Cush rule number 6 is with natural products, the more it costs, the less it works. Meaning they're just bilking you from your money, feeding on your desire to treat something naturally, like with probiotics. So, I'm a big believer in a Mediterranean, gluten-free, no carbohydrate diet for psoriatics and for spa. I've got hundreds of examples where it works really well. Have I done a trial? No, we've done a retrospective review. And the problem with a lot of these people is that they have very few joints going in and very modest activity scores. So the improvements, which they say are big, don't numerically show up as being that big. But nonetheless, it's fairly cheap. Patients are motivated to do it. When you give patients control, it may have a tremendous placebo effect, but I've been shocked. And I mean, seeing devastating disease go to zero just with a diet. And then part of that regimen, because of patients who I talk to a lot, is probiotics. And I think personally, I think you need to be with multiple strains, like 4 or 5. And I think you need to be in the hundreds of billions of CFU counts. A lot of the commercially available stuff is not even close to that. And I'm not talking about multiple drugs a day or a lot of money. I'm talking about, I take a PB8 every day, and I'm good and done. And it's, cost me $26 for a 3-month supply. So I think there might be, and there are studies, I must say bad studies, showing that probiotics do work in RA. But for every one of those, I can show you one that didn't work. So this is a highly contested area. Most of the things that you're ingesting are dead. And the question is, can you redefine or reshape your microbiome based on this kind of a ingestion? I don't think anyone really knows. But I'm pretty certain it doesn't harm. And I do think I'd like to see more research on this. So, Robert, what's your final one so we can end?
Yeah, 2246. Big study, also real world data on switching or discontinuing biologics in psoriatic arthritis. Large retrospective database in Japan. Over 15 years, they used claims data, looking at switching or discontinuation kind of patterns for about up to 2 years. Over 700 patients, and very broad spectrum of biologics. They had the typical players in TNFs, adalimumab and certolizumab. They had IL-17s, brodalumab, secukinumab, and ixekizumab. They had risankizumab and guselkumab, even ustekinumab. And they found that, just as a whole, in all the biologics at the 12-month mark, about 38% discontinued, 49% switched. 24-month mark, 22% discontinued, 31 switched. But interestingly, the interesting data here is risankizumab had the lowest discontinuation rate at 21% at 12 months and 32%. And that was followed number 2 by ustekinumab. So 2 things. Number 1, I feel like definitely the Japanese rheumatologists are using, it sounds like a way broader spectrum. And they actually had 2 other biologics. I forget off the top of my head. They just didn't have enough data on those 2, so they didn't include them. So they're using I think a far broader spectrum of biologics than us here. And number 2 is, I think, really surprising data on the longevity, if you will, from this singular study on risankizumab and IL-23 inhibitors.
Yeah, this data dovetails with a lot of reports coming out of the psoriasis world, but also in psoriatic arthritis, about the disappointing durability of the drugs that we often use in patients with psoriatic disease. That it's nowhere as close to those numbers you would see with RA and methotrexate. 50-70% persistence on the drug over time. A lot of these studies looking out at 2 years, it's only 30% are still on the drug that they started, and so there is a lot of switching. There is a lot of discontinuation, and the persistence. I don't know if that's efficacy, how long they've been on the market, the marketing of the drugs, on television and whatnot, or the number of remaining alternatives that are at the disposal of the clinician and patient that would lead them to switch and switch and switch and switch and switch. Don't worry, I got another one for you, and if you wait 2 weeks, there's a new one coming. That whole idea. So, I in some ways I find this bothersome, but I don't know what I need to worry about most. And I guess the bottom line is that if the patient's not doing well, they're not doing well, and you've got to. Then again, what's the definition? I'm sure this kind of study doesn't have a criterion for why they switched. It's whatever happened when that door is closed in the clinic. So, Orly, what do you think about this data?
Yeah, no, I mean, I think, I think the question always is also if you compare with RA, but there have so many more reasons to not doing well if you think of it, right? Because their joints can be fine, but then their skin's not fine. Their skin's fine, but they have like enthesitis, or everything is fine, but they do have dactylitis. And I think that's one of the problems. I think in RA, if you treat the joints, and you can see it coming, but then in PSA, the problem is there are so many domains you need to address. And I think I'm not saying this is the only reason, but I think this is probably one of the reasons why we see such a low maintenance over time.
That's a really, really important point. I'm so glad you made it, because PSA patients are complex because of the multiple domains that they have in play. And I remember a report from Alexis Ogdi from a few years ago where I think she showed that the average patient had like 3 or 4 domains, and it wasn't uncommon to have more than that. Maybe there's something like 9 total domains that one could have with psoriatic disease. So yeah, there are multiple reasons to fail, and we know our drugs are not equipotent in treating the skin or the joint or the enthesis or the eye or go on and on and on. Robert, you get last comment on this report.
Yeah, and I think just completely agree that it's tricky to treat these patients, and sometimes it's not even just the efficacy; it's how the patient responds to the drug. I have, I can't tell you how many messages or phone calls I get sometimes from, hey, I had this side effect. You're not going to argue with the patient. You can't say, hey, this is not a listed side effect. They felt it and they want to switch. They had a site reaction, and there's so many things at play with this. But I think at least it brings to attention that I think one, like everyone mentioned, multifaceted approach of psoriatic arthritis, and number two, longevity is still one of those kind of holy grails, I guess, if you will, in treatment of psoriatic arthritis.
Yeah. I want to thank our audience for tuning in to this psoriatic arthritis panel discussion. If you're really into psoriatic arthritis, there's yet another podcast that's coming out soon. And it's called the Psoriatic Arthritis podcast from ACR, and it's going to include all the psoriatic arthritis reports from the faculty strung together, so you can watch that. Tune into other panel discussions coming up in the next few days. I want to thank Orly and Robert Chow for guiding this discussion. Take care.
All right, bye.
Hi.